Okay, guys, we'll go ahead and get started and let people come in as they get their lunch. It's my pleasure today to introduce one of our visiting professors for 2016-2017. Dr. Brenda Hemmelgarn has come from the University of Calgary. She's a practicing nephrologist. She has a PhD in epidemiology as well. She is the professor of medicine, currently holds the Roy and Vibey Chair for Kidney Research, and is the head of the Department of Community Health. She's a prolific researcher with over 400 publications in the area of chronic kidney disease, hypertension, diabetes, cardiovascular disease. And I think she's really shown an adeptness for implementing that research into the population and improving her patient population's health. So it's a real pleasure to have you here. Thank you, Brenda.
Thank you, John. And thank you. It's a real honor to be here. It's actually a really humbling experience to be among such a distinguished group as you, but a real pleasure for me to be here. So thank you to everyone for the opportunity. So what I'm going to do is I'm going to tell you a little bit about some of the research that we've been doing in Alberta with the Alberta Kidney Disease Network, and tell you a little bit about the health information systems that we've been using there to give you an idea of some of the linkages that we're doing in some of the studies that we've conducted and some that are underway, and always looking for opportunities to collaborate. Had some great discussions with the fellows this morning, and we've got some ideas going. So if there's others who are interested in this data source as well, always keen to collaborate. I'm going to end off with a little bit about lessons learned from the projects that we've been doing. Really, my focus now is trying to enhance CKD care in the community area, in particular as a practicing nephrologist. So chronic kidney disease is common. It affects, the prevalence is about 12.5% in Canada, and very similar prevalence estimates in the US as well. It's more common amongst elderly, and in fact, the prevalence will increase to anywhere between 20 and 25% amongst those age 65 and older, so a common condition. And the often understated fact is just the poor quality of life and poor survival amongst patients who already are on dialysis. It actually mirrors those of people with metastatic breast and other types of cancers. So a poor quality of life amongst end-stage renal disease patients in particular. Thus, the emphasis and focus in my research on slowing progression and ideally preventing the development of end-stage renal disease. There are effective treatments together, and we've known for over a decade, in fact, about the benefits in terms of angiotensin blockade, a number of meta-analyses that have been done showing that it reduces the risk of end-stage renal disease amongst those with proteinuria, irrespective of their diabetes status, and the risk of death is reduced amongst those with diabetes. So effective treatments are available. But the issue is, how do you actually incorporate that evidence into clinical care and into practice? And that's an area we've really been focusing on. There's definitely a care gap that's been identified. We've got the guidelines, but how do you implement that in practice? We use some of the data, and I'll tell you about our data sources in a bit, but just to show that in Alberta, up to 50% of elderly patients with chronic kidney disease were not on recommended cardiovascular medications. And of those elderly patients, only 20% who met the criteria for a specialist referral were actually seen by a specialist. So clearly some additional work that needed to be done. And that's what we've been focusing on with the Alberta Kidney Disease Network. So the network is in the province of Alberta, in Canada, the Western Province in Canada. And what it is it's collaborative between the two university affiliations, the University of Alberta in Edmonton and the University of Calgary in Calgary. And what we've done is we've maintained a repository of laboratory and administrative data, and as well as renal program data to help us undertake these various studies that I'll talk to you about. So overall, there's about 4 million adults, and we've got data and laboratory data spanning from 2002 is when we first started up until currently. So I'll tell you a little bit about that, but just to put it into context, when we talk about healthcare coverage, just to remind you about the healthcare coverage in Canada, because that has implications in terms of the data that we have. So there is universal health care in Canada under the Canada Health Act that was implemented in 1984. And what that does is provide residents of the various provinces with access to what's known as medically necessary care without payment. So really what that is, it covers physician visits, emergency department visits, it covers hospitalizations, It covers investigations including laboratory and diagnostic imaging. There is some private providers. It's not illegal to have private provision, but it's highly discouraged. And because they are private and the patients have to pay, the utilization is pretty minor. The things that aren't funded privately are prescription drugs. About 54% are funded privately, and that's typically individuals who are 65 years of age and older. They have their prescription drugs covered. Otherwise, there's either covered individually or by insurance plans. And the majority of vision care and dental care is funded privately as well. So the big ticket items are the physician claims, hospitalizations, laboratory data, and drug data that are covered without payment. I should mention that even though the drugs are funded privately, they are maintained in a database. So when a pharmacist dispenses a prescription, it's actually maintained in the database. So irrespective of how it's funded, we do have access to the drug data as well in Alberta. So what we've done because of the manner in which the healthcare is administered in Alberta, Alberta Health Services, Alberta Health and Wellness, the ministry in the province, has maintained a number of individual registries that are linked with a unique identifier. So everybody in Alberta has got a provincial health number, and it's used to link all these various data sources. Any healthcare is all tied back to that unique identifier. And so within Alberta Health and Wellness, there's a registry file that includes everybody who's registered in the province. There's Alberta Blue Cross, which is the drug file. There's the ambulatory care file, which is outpatient visits, emergency department visits. There's the inpatient encounters, and that's all the hospitalization data. And there's also the physician claims data files. And all those files, again, can be linked with the provincial health number. And so what we did with the Alberta Kidney Disease Network is we created a repository of laboratory data from across the province. Laboratory data is not maintained by Alberta Health, but we created our own repository, went to the various labs across the province, obtained the laboratory information and continued to do that prospectively, and linked it to the administrative data files. And so we also have records of the lab data. And that's particularly relevant in kidney disease because kidney disease is defined by creatinines and eGFRs. So we can define cohorts either using the administrative data sources, or if we want to create a cohort of patients with kidney disease, we can use the laboratory data. And we also have linked that to our renal program data in the province for outcomes like dialysis or transplantation. So that's really formed the basis of the work that we do, and this is very consistent actually with a lot of the work that's underway in the US, and part of the group that I'm involved in and that Blake is involved in here is through the NKDEP, the National Kidney Knowledge Information Program, and they're really looking at how you can use health information technology to improve CKD care. So similar to the work that we're doing, looking at EMRs and administrative and other data sources to improve care through both community-based systems and health systems. And I just thought this was a really nice framework to frame kind of the context of what we're doing. So I'm going to give you a few examples of some of the projects that we're doing to show you how we've utilized the data and how it's been used, hopefully to improve care for patients with kidney disease. One of the first studies that we did, we looked at something called eGFR reporting. So back in the early 2000s, the guidelines, both nationally and internationally, actually recommended the reporting of GFR in addition to creatinine as an estimate of kidney function. The gold standard for kidney function estimation is a nuclear medicine test, but that's expensive and time-consuming. And so rather than using something like that, an eGFR, an equation that takes into account age and gender and body surface area, is actually used to estimate GFR. So it's much more accurate than a creatinine alone, especially for the elderly individuals and for females. So that was about 2002 when the guidelines recommended that eGFR be reported in addition to the creatinine to estimate kidney function. And they recommended that it be reported on the laboratory report forms. And so Alberta, we were working closely with the labs, and we're talking to them about reporting of eGFR. But there's lots of concerns. There were concerns about reporting it because they thought that people would be mislabeled as diseased when they might not be diseased, with a GFR of less than 60 defining chronic kidney disease. And there was lots of concerns amongst the nephrologists, my colleagues, who said, we're just going to get a ton of referrals of people that probably don't need to see us. We're not going to be able to see the people that we really do need to be seen. And so I said, okay, well, we'll implement it, but we'll also study it. We'll see who we're seeing, and is it making a difference in terms of referrals, and are we seeing the right types of people that we should be seeing? And so we did that. We used our data sources to define a cohort of adults who had at least one outpatient creatinine. So we used our laboratory data file, and that was about just over 1 million individuals. And our study period was 2003 to 2007. So we used an interrupted time series design, and we looked at the period before as well as the period after the implementation of the GFR reporting. And in particular, we looked at new referrals to nephrologists during that time period. And this is what we found. So we did an interrupted time series and looked at new nephrology referrals, and we stratified it by eGFR of less than 60, which is on the left-hand side, and eGFR of less than 30, which is the figure on the right-hand side. The x-axis is the months and years, and we had a transition period here of about 3 months when the GFR was first reported, a washout period to allow time for new referrals. That was about the wait time to see a nephrologist. And what we found is that the rate of new nephrology visits increased by about 68% for the GFR less than 60 group, and it increased by about 63% in the less than 30. And these are the individuals actually that the guidelines recommend referral for, the GFR of less than 30. So there was an increase. The blue lines at the bottom are individuals, the non-CKD group. So there was no change in the referrals of those individuals with a GFR of greater than 60. So it did increase the referral rate, but you'll also see that there was starting to be a decline in the less than 30 group over time. And we haven't looked at this again, but we should actually, just looking at that. So we did find that there was an increase in referrals, and we looked at the subgroups to see who was being referred. And the increase was primarily in females and the elderly, and patients with a GFR of less than 45. So the types of individuals who are typically missed if you're looking at a creatinine alone in terms of a need for a nephrologist referral. We also looked to see if it actually improved markers of care for this population, and it wasn't associated with an increase in use in ACE or ARBs, the medications that are indicated in this subgroup, even the highest risk subgroup, the diabetics with proteinuria. So it increased referrals, so there was more people that were seeing nephrologists, but a large proportion of these individuals aren't seeing nephrologists, are still out in the community, and it didn't have any impact in terms of processes of care outcomes. So it is a more accurate way to identify CKD than creatinine alone. It does increase referrals, but is this the type of population that we need to see? And does it improve patient outcomes is really the important question. And actually the work that we've done, there's a number of other groups that have looked at GFR reporting and provided similar types of results as well. And this is some work from Virginia Wang and the group using the VA data, where they looked at recognition of CKD before and after eGFR reporting, and had similar results actually. They looked at the recognition of CKD by either diagnostic testing, ICD codes, or testing using a microalbuminuria, kidney biopsy, or an ultrasound. And so you can see the light-colored bars are before and the dark-colored bars are after GFR reporting. So overall, there's a 21% increase overall. So there's increased recognition, but still the question of whether this actually does improve outcomes remains. And there's a number of other studies as well. So we took a look and we said, okay, maybe eGFR reporting isn't enough. So what we did is we reported the GFR, and we had a little prompt that said if the GFR is less than 60, this patient may have chronic kidney disease, and we referred them to our Alberta Kidney Disease Network website for further information. And we also said if the GFR is less than 30, a referral is indicated to a nephrologist. But maybe it wasn't enough. We thought, well, maybe that was just too general. Maybe what we need to do is provide them with more detailed information in terms of how to actually manage patients. Maybe we should be telling them about use of ACE and ARB. And so we decided to do that study, so looking at whether a more detailed management prompt on the lab report form would actually improve care and outcomes. And we did this one in a cluster randomized trial fashion in the province. So what we did is we had 93 GP practices in 3 different health regions, 2 rural health regions, one in the northern part of the province and one in the southern part of the province. And then we also had 1 large urban region. And what we did is we worked with the labs, and the labs were able to identify patients with GFRs of less than 60 and physician practices. So we cluster randomized the GP practices to receiving the more detailed prompt versus not receiving the detailed prompt. So the control group was just the standard prompt, the standard eGFR reporting, and the treatment-based prompt had more detailed information, suggesting measurement of a urine albumin to creatinine ratio, the use of an ACE and ARB, and listed the indications, referral if the GFR was less than 30, and then also blood pressure targets and LDL targets for this population. We followed them up for just over 2 years, and we had 95 physician clinics, 420 primary care physicians that were randomized to the standard or to the enhanced prompt. So 45 clinics in each arm, representing about 10,000 patients and 11,000 patients with CKD in each of the 2 arms. The primary outcome was a composite endpoint of death, end-stage renal disease, doubling of creatinine, and MI or hospitalization for heart failure or stroke. So the cardiovascular complications and related complications. And there was no difference. There wasn't a reduction in the overall cohort of those with a GFR of less than 60. There was no reduction in the composite endpoint. And there wasn't a reduction either in those with the subgroup with a GFR of less than 60, or amongst elderly patients with diabetes or proteinuria, so one of the highest risk groups. So it didn't affect change. There was no difference in nephrology referrals, and this isn't that surprising though, because the other prompt had actually already recommended that. And we also looked to see if there was difference in ACE and ARB use in the control arm versus the other arm, and there wasn't either. So, and there's a number of different studies that have been underway and projects that have been underway at this time, also including other lab prompts, but really a passive intervention like this, just simply providing the information there to the provider, did not improve the management of this patient population. So we had adequate power, but we thought, why was there no effect on outcomes? And I think one of the reasons is that we did have, the follow-up was short, although we still had that into account in our power calculations. It was 2.1 years. The baseline use of ACE and ARBs was already quite high at about 77%. It was actually higher than we had anticipated. And then we thought, well, maybe we should have chosen a higher risk group. But maybe the ultimate is that we need a multi-pronged education approach. And that an approach like this, which is very passive, is not going to be a way to change as behavior change method. And I think that was the big take-home message from this. So then the question becomes, so if a simple prompt didn't change, it did increase referrals, it probably increased recognition, should we continue doing the laboratory reporting of GFR? I think we should in terms of reporting the GFR, just because it is much more accurate. But I think it's going to be a lot more and take a lot more than just a passive reporting of a prompt on a laboratory report form. The other thing that we've changed in nephrology is our appreciation and understanding that it's more than just about a glomerular filtration rate. There's more to kidney disease than GFR. And the other point that's been important probably over the past 5 to 10 years, I'd say, is just the recognition about albuminuria, so the measurement of a urine protein that's a marker of kidney damage as well. So this is something that's really been incorporated now and has really changed the guidelines as well as our processes of care. So we looked at this in terms of albuminuria as a marker, or proteinuria as a marker of risk in patients with chronic kidney disease using, again, our laboratory data sources. And so what we did in this study is we created a cohort of just under 1 million individuals who had a measure of both creatinine to estimate GFR, as well as, in this instance, we used a urinary dipstick. And what we did is we looked at outcomes of all-cause mortality, of AMI, end-stage renal disease, and doubling of serum creatinine. We categorized the proteinuria as normal, mild, and heavy. Mild is the red and heavy is the dark blue bars. And then we looked at these outcomes adjusted for comorbidities and demographics by level of GFR. So GFR greater than 60, and then all the levels below 60 indicating the severity of chronic kidney disease. And I think what you can appreciate here is that across all levels of GFR, the increased levels of proteinuria were also associated with increased outcomes for all the outcomes, the mortality and the renal outcomes that we studied. So this was actually in 2010. We also looked at proteinuria as defined by albumin-creatinine ratio and protein-creatinine ratios. They were smaller cohorts, but similar results were obtained too. So this data was actually used and used with the CKD-PC, the Prognosis Consortium that Joe Koresh runs out of Johns Hopkins, where he meta-analyzed this data, and that data was used actually to inform the 2012 International Kidney Guidelines, where we now categorize CKD by both GFR as well as by albuminuria categories. And this, I think, is just a nice heat map which shows the increasing risk for various outcomes, end-stage renal disease and related outcomes by the shading. So showing that the highest risk groups are those with the highest degrees of albuminuria and GFR and the lowest levels of GFR. So just a nice depiction in something that has influenced the guidelines internationally. So these international guidelines were published in 2012, recommending now the measurement of albumin to creatinine ratio to risk stratify patients and for management as well. So I was very excited when these were published. I thought this is going to be great. I worked with the group actually on the guidelines. And as in any case in guidelines, when it's something especially of an international nature, the first thing you have to do is take it locally and say, how can these be applied at the national setting and more relevantly at the local setting, the local application. So that's what we had to do next. We had to look at how provision of care was provided in Alberta, recognizing that, in fact, 95% of patients with chronic kidney disease are managed in primary care by primary care physicians alone. And it's only those with more severe kidney disease that are managed by nephrologists. So these guidelines, in fact, are the target audience for them are primary care providers in the community. So I thought, okay, to get this information out, and especially aspects like measuring ACR and what to do with those measurements, we really have to get out into the communities to primary care. So we did a lot of work. Started off just by actually talking to some primary care physicians and showing them the guidelines. And the first thing they said is, I don't want your 180-page document. I'm not going to use it. So leave me alone. So that was a very clear message that was consistent. And so we realized that we were going to have to do more work in understanding how primary care is delivered in the local setting and develop tools to actually translate that evidence into practice. So we had to understand the EMRs that were available in the primary care physician's office, the laboratory systems, and really how they functioned in terms of referral. And the way that we did that is, it took about a year actually. We did focus groups with primary care physicians to find out what manner would best suit them in terms of receiving this type of information. We did surveys. We surveyed patients as well as other care providers, because we were looking at the barriers and facilitators to this knowledge transfer at the physician level, at the provider level, and at the health system level. So really trying to understand the best means to get it. And we heard some common barriers that were repeated consistently. And one of the barriers, especially the physician level barrier from primary care, was just the uncertainty that they had in terms of when to refer patients in particular, when to measure an ACR, and what to do with those results. And their constant comments about the guidelines not being concise or consistent. And so they wanted something that they could use at the point of care. That was a consistent message we got again. If they had a patient in front of them, they were seeing them in clinic, how could they access the information that they needed about management of patients with chronic kidney disease in 3 minutes, they said. They want to be able to access the system, find the answer, and deal with the patient that was in front of them. So we heard that and decided that we had to really tailor and target it for the patients. So we heard they wanted something practical, available at the point of care. They wanted it integrated into their clinical care so that it worked within their workflow. And they also wanted it harmonized with other guidelines. They said the worst thing is when they get conflicting information from different guidelines. They said provide us one document that is consistent in terms of providing all the guidelines. So what we did is the message we kept getting back from them is they said, well, why don't you provide us with a clinical pathway, so like an algorithm, so if a patient has how to diagnose, manage, and refer patients based on an algorithmic type pathway. And so we did a number of visits, site visits with different primary care physicians' offices just to find out a lot about the workflow, how they're using the EMRs, how they're accessing their labs. We contracted a web designer firm to work with us in designing a clinical pathway online. And then we took that back into the physicians' offices and did what's called wireframing and made modifications as we were implementing and developing this pathway to make changes so that it would be something that would be usable for them in their clinical practice. And this is what we ended up with as our final endpoint, is a clinical pathway that's available, freely available online. We wanted to make it accessible so that it wasn't limited within an EMR, because then it would be only accessible to the physicians within their EMRs. But this is now accessible beyond Alberta. It's accessible anywhere, in fact. And what it focuses on is the diagnosis, medical management, and referral of patients with for chronic kidney disease in particular. What we did is we combined the evidence-based guidelines from the diabetes guidelines, the hypertension, and the kidney guidelines to make them consistent. So I'll show you a few screenshots just about the pathway. So this is, if you hit the Diagnose tab, what they can do is there's a drop-down menu here where they can enter a patient's GFR, albumin to creatinine ratio, the ACR, and whether or not they have hematuria, and click the Diagnose button, and it'll say whether or not the patient has CKD, and then the following is recommended. In this instance, it's medical management. So we've also programmed in the criteria for referral based on eGFR, ACR, and hematuria. And so depending on what their level of GFR, ACR, and hematuria is, it also tells them whether or not a referral is indicated. So in this instance, a referral isn't indicated, but it says the patient has CKD. So those are the tabs that you could hit. Under medical management, we've got some lifestyle modifications that they can utilize. And then there's also drug therapy. So management of chronic kidney disease is really cardiovascular risk reduction is what you do when you manage a patient with chronic kidney disease. So we focused on three aspects of drugs therapy: ACE and ARB use, statin use, and antiplatelet. And what we did is we provided the same sort of information, so a little bit about the prescribing information, the dosage of the drugs, the contraindications, and general information. So that's the drug therapy that we focused on. So if they've got a patient and want to know if they should be on an ACE or an ARB, they can click that tab and it'll give them all the prescribing information. We also heard from the physicians that they wanted handouts to provide their patients. And so if they're talking to them about a low sodium diet, for example, they can click that print and actually print off a sheet for low sodium foods. So as much as possible, we tried to include handouts that the physicians could provide to their patients. The other thing we heard a lot about was when do we refer patients and how can you help facilitate referrals? So we've got some other initiatives that are underway now. I'll talk a little bit about them a bit later, but what we've done within our clinical pathway here is also indicate whether a referral is indicated based on the criteria that are programmed in, but there's also a referral tab that lists the criteria. And if it meets the referral criteria, it'll actually indicate refer to a nephrologist. And it also has the referral form that's available there so they can print off the form or complete the form. So it's really, what we've aimed to do is to provide it one-stop shopping in terms of the information. They wanted things that were practical and feasible. So it's there. We implemented it in November 2014, but does it make a difference? Like, that's the big question. Is anybody using it? Is it going to change management in the community setting? Is it going to change the behavior of providers in terms of their management? That's the big question. And so we're going to evaluate that as well. What we're doing is we've done some preliminary evaluation, mainly looking at uptake, something that we can do quite quickly. When we first implemented, we did telephone interviews as well as surveys of people who were using it. So we got some quick information in terms of did they like it or how were they using it. And we're also using Google Analytics to look at some hits. So the preliminary stuff, and again, this is very preliminary, it just really shows you how it's being used and what the users are thinking about it. So the results of our interviews and surveys suggest they feel that the pathway helps to enhance communication in a team setting. And we heard that they're using it in their multidisciplinary care settings in particular. The nurses and pharmacists are also able to utilize it. So they feel it enhances the team communication and facilitates the training. 81% that were using it on the survey says that it increased their knowledge and confidence. Again, this is the users. We don't know anything about the non-users, which is the major limitation of this. And 94% that it felt that it provided useful information. So it seems we got the information that they wanted. We're also tracking, using Google Analytics, the number of hits, the number of sessions over time. And this is a 2-year period from November 2014 when we first started until November 2016. So there is some increased use. And what we're also looking at is to see, we've got a variety of different dissemination strategies. We give talks or CME events. We've had some mass media blitzes. We've had some facts out. So a variety of different dissemination strategies. And what we're trying to do is correlate the different methods of dissemination to the hits on the website to see which has been the most effective method of disseminating to this community-based provider population. And the other thing we're doing with Google Analytics is just looking at the number of users, whether they're new users or return users. And pretty consistently over the 2-year period, there's about 2/3, 1/3. So about 2/3 are new users and 1/3 are return users. The majority of people are from Canada that are using it, but we've also tracked other countries. And Indonesia is the second most highest country. I'm not sure why. And then the USA. And then we look at which pages they're hitting and what duration of time they're spending on each of the pages. And then we're going to evaluate longer-term outcomes as well. So we're going to use, again, an interrupted time series design, looking at before the pathway was made available and after, and our administrative data sources to see, does it change care in the community? Does it increase in processes of care outcomes? So proteinuria assessment, ACE or ARB use, statin use. And we've got 2 years of follow-up now, so we're also going to look at other outcomes like hospitalization. I think it's still too early to look at progression to end-stage renal disease, but we can continue to track and monitor that. So that's one thing that we're doing with the CKD pathway. And I just want to talk very briefly just about a couple of other tools that we're using, and again, using our administrative data sources as outcome measures. So the beauty about these administrative data sources is that they do have the information in terms of comorbidities. You can define comorbidities or other outcomes, death, end-stage renal disease, and clinically relevant outcomes. So a couple of other things that we've been doing, and again, focusing on earlier stages of kidney disease. So one of the things that we're looking at, and one of the things we've heard a lot from the primary care physicians, is just the difficulties in terms of the referral process in Alberta. Currently, it is not electronic. It's typically physicians will fax a referral into a central triage, and it'll be triaged. What we're trying to do, though, in Alberta is move everything over to a single system called NetCare and have the referrals uploaded electronically into a common system. So the primary care physicians would upload the referrals to whatever specialty that they wanted to send them to, and there'd be a tracking system so the primary care physicians could see when their patient has been triaged to be seen, how long until they're going to be seen, and when they're actually seen. Because what happens right now is they'll fax in the referral, and it goes into this almost like a big black box, and they don't know where their patient is in terms of being seen unless they call the triage clinic. So what we're aiming to do is utilize a provincial system called NetCare to utilize to improve the referral process. That's going to take about 3 years, but in the meantime, what we're doing is providing what's called an e-consult service. And what that is within the NetCare system, so within this electronic health system, a physician can write in their question based on a patient. So they go into NetCare, and NetCare is patient-based, and so they'll pick the patient that they have the question on, write the consult in, and then post it to the nephrology service, and they can pick the service that they want in whatever community. And then within 3 to 5 working days, a nephrologist will respond. So it's like almost like an email exchange. We can't use email actually in Alberta because of privacy laws, but this is one way of communicating electronically between providers through the healthcare system that's available currently. So we're just starting to do this now, and we're looking at a cluster randomized design, similar to what we did before with our cluster randomizing primary care practices to see the impact of the e-consult. There is a challenge though, and the major challenge, this is the NetCare system, the Alberta NetCare portal. So it covers the entire province of Alberta, and it includes all the healthcare information. So it includes the drugs, it includes their labs, it includes the diagnostic imaging tests, information about hospitalizations and physician visits and consult letters. It's all there within NetCare, and it's available and accessible to all the providers. But the problem is that family doctors, our target population, have a separate EMR. So they've developed an EMR. There was financial incentives about 10 years ago for them to implement EMRs into their primary care practices. And their EMRs, which is TELUS Health, doesn't speak to the Alberta NetCare portal. So there's 2 separate systems. So what the family docs have to do to use this e-consult or e-referral system is they have to go out of their EMR and log into the NetCare system. So it's a barrier that we're trying to overcome. They're developing a new clinical information system provincially, and so hopefully with that new system, they're trying to integrate the primary care EMRs into that provincial system to overcome this potential barrier. I just want to end off just telling you about one other tool that we've been working on with our primary care colleagues to facilitate care in the community, and that's something called a comprehensive annual care plan. So it's probably about 10 years, in 2009 actually, in Alberta, they recognized that the patients that primary care was seeing, they were seeing a lot of complex patients. And there was no incentive for them to see complex patients any more than see somebody with a simple health problem. And so what was happening is some physicians were even restricting their practices and not seeing patients with complex care. And so what they did in the province is they provided a special fee code for patients with certain conditions, comprehensive complex conditions. And what they did is primary care physicians can bill this fee code if they complete a comprehensive annual care plan on these patients once a year. So it's a financial incentive actually. And these are the different conditions. So to be eligible for this comprehensive annual care plan, you have to have 2 conditions in Group A, so hypertension, diabetes, COPD, asthma, heart failure, ischemic heart disease. And when this was initially implemented, it didn't include chronic kidney disease, but we were able to show them and provide them with a business case and have chronic kidney disease added as one of the billable conditions about ECHO. So once a year, if a primary care physician sees an individual with this combination of conditions that meets the criteria for the annual care plan, they can complete this care plan goal setting between the provider and the patient. The physician signs off on it, the patient signs off on it, and the aim is to improve the care and outcomes for complex patients. So we thought, okay, if we can add chronic kidney disease in here and provide them with some tools to help them complete this care plan, maybe this will be, and it's a financial incentive, but another way to increase and improve care for these patients. So in this project, what we're doing is we're working with TELUS Health, so we're working with the EMRs that provide, they're the vendors for the primary care EMRs in the province. So over 80% of primary care physicians in Alberta use one of the 3 TELUS Health EMRs. And what we're doing is we're working with the EMRs to identify patients with CKD using their dashboard. Then we see if they're eligible for the comprehensive annual care plan. And then if they are eligible, what we've done is we've facilitated completion of that care plan by uploading information and linking it to our care pathway. So I'll just show you those steps. So the first step is on their EMR dashboard to identify patients with CKD. So when the physician goes to the dashboard, they can open up this box and it says consider chronic kidney disease. And in that box, potential patients with chronic kidney disease are identified if they've got CKD documented in text, if they've got a diagnostic billing code, at least two billing claims, or if they have a GFR of less than 60 or an ACR of greater than 3. So it says, consider chronic kidney disease. So the physician will go to that individual patient and take a look, and if it is confirmed, they'll then label it as confirmed, and they'll be defined as having chronic kidney disease. So the ICD-585. So then what they do is they determine eligibility for the care plan. So if they've got chronic kidney disease, that means they've got one condition in that group A, and then they'll look to see within the EMR if they've got diabetes or hypertension or the other criteria to make them eligible. So this will then provide a list of patients who are eligible for that care plan. And then if they are eligible, what it'll do is it'll take them directly to the care plan. And what we've done is we've integrated information based on the guidelines that will help to facilitate and establish the goals for the patient. So the lifestyle changes, for example, the blood pressure targets, whether or not they need an ACE or an ARB, whether a statin's indicated, all that can be hyperlinked and uploaded. And because this is in the provider's EMR, it's patient-specific, so it'll have the patient information right there, so specific to the patient. So it'll have the eGFR, for example, that's patient-specific. So they can, by the click of a few icons, develop a care plan that's evidence-based and that's specific for this individual patient. Print it off, go over it with the patient, and meet the criteria for the comprehensive annual care plan. So we're just finishing that now and going to be rolling that out. So our initial pathway was about 2 years ago, so we've had a 2-year time lag now, and we'll roll out this. And again, we're going to use an interrupted time series so that we can include the entire province in the evaluation. We talk about all these different types of projects, and they're keen and they're innovative and they're neat to do, but unless you think about how you're going to actually scale and spread them in the long term, if they are effective, and if not, why not, and how can you change them? I just wanted to raise the point that it's one thing to design these, but it's also important to consider the scale and spread of these interventions in the long term. And in particular, to adapt them if they don't work, look at what works, what doesn't work, and adapt them accordingly. And the other important point that I wanted to make is just the importance of sustainability of these things, and something that has to be thought out right at the onset. Again, it's one thing to develop a pathway and post it on a website, but somebody's got to update it with the latest information or change the guidelines as they change, or modify it if it's not working. So the whole issue of sustainability is important. And the way that we've undertaken that in Alberta, there's something called strategic clinical networks. And what they are is they're a link between really the universities and Alberta Health Services, the operations. So they're embedded within Alberta Health Services, and they're very therapeutic related. So there's a kidney health strategic clinical network, for example, and their mandate is to help facilitate the evidence and bridge that evidence practice gap. So they're in frontline operations, and so they've been fantastic in terms of helping both implement and looking at long-term sustainability of these types of interventions, if they do work, and if not, modify them accordingly. So what have we learned? So it's been a lot of fun doing this. We've got a great team to work with, but we've learned a lot too. And I think one of the important things that we learned is just the importance of an integrated KT approach in designing these projects and having the right stakeholders at the table early and often to provide their input, especially for that working with primary care and other types of providers. I think a pathway that I would have developed as a nephrology would be very different than the one that we've got now, thanks to the input from primary care. It takes time and a variety of resources and different funding sources to utilize these. And again, just the importance when you're doing these sorts of tools and considering scale and spread and sustainability in the long term. And I just wanted to end off just by talking a little bit about our Alberta Kidney Disease Network, again, just to take you back to that and talk about some of the opportunities that we've had and some of the challenges with that data sources in the network. I think one of the opportunities is a geographically defined population. It's a provincial population. I think another opportunity is we've had great partnerships with the labs, in particular with the clinical chemists, that really helped facilitate a number of these different projects. The GFR reporting, the cluster randomized trial prompt study. It's been because of the partnerships with labs. It's also an opportunity for pragmatic interventions. Again, we've used these administrative data sources for outcomes. We've got another trial right now that we're looking at randomizing at the individual patient level for co-payments in high-risk patients with cardiovascular disease. And we're going to be using our administrative data sources for outcomes. So it is possible to do pragmatic interventions with them. But there are challenges for sure. I think one of the biggest challenges is our outcomes are really limited by the data sources that are available. The hospitalization and physician claims data. We don't have information on quality of life, for example, or other patient-reported outcomes. So it lacks that patient-centered approach using those sources. And really, we're missing a really high-risk population. So we have people who access the healthcare system and who get a creatinine drawn, for example, but we don't have access or information about those who don't access the healthcare system, and that's another huge high-risk population that we aren't able to study. And another challenge, but it can be an opportunity as well, is just the need. I think we've really understood the need for multi-pronged approaches in this type of work when you're looking at behavior change in primary and provider care settings in particular. So what I've tried to do is give you an overview of the work and the health information systems in Alberta that we're using in kidney disease and efforts that we're trying to improve CKD care, and a little bit about the lessons learned from these projects to enhance CKD care in the community. And I just want to acknowledge our collaborators in Alberta, in particular to Braden Mads and Cello Tonelli, who've done a ton of work, as well as our research staff. And it is Valentine's Day, so I just wanted to thank you for your attention, and from our country to yours, wish you all a happy Valentine's. So thank you.
Now, I warn you ahead of time that unlike Canadians who are incredibly nice and intelligent, we tend to be more honest here, just so you know. It's a warning. First, the remarkable compliments for first building that system. It's amazing, the data that you've got out of it. Second, identifying a big problem and being able to study and sort of quantify how huge the gap is between what we ought to be doing and what we are doing. And third is to do evaluations on all the interventions you've done and come up with these creative interventions. But getting back to problem number one, which is, are you just too nice in Canada? Are the interventions you're putting in place way too nice to affect a problem that really should take a stronger stick? And I'm kind of serious about this. In part, we've repeated multiple times in multiple settings that more information to docs doesn't necessarily affect behavior. And other sorts of reminder systems probably by themselves often don't work either. And even when they do work, they don't sustain, or they won't multiply. If you try to do it in 20 different conditions, it sort of falls apart in those settings. Do we need to go stronger?
Stronger in terms of policy?
Performance measures, public reporting, pay for performance with real dollars attached to it, not sort of buried on the side, a little bit of reward somewhere.
So we have talked about that, and there are some audit and feedback mechanisms that are being used in the emergency departments in particular, and some report cards that they're doing. And so it is heading in that direction. You're absolutely right. Everybody is very polite and in Canada, and a bit hesitant to impose some of those sorts of things. But I totally agree with you, and I think that's what we've really learned, is that the passive approaches, they're not working. They don't change behavior. And so there has to be, that's why we looked at the financial incentive in terms of the comprehensive annual care plan, but that's a positive financial incentive. What if there's something that was negative that said, if you didn't do this, you're not going to be able to bill for this condition, or those aspects? I totally agree. It's got to be more aggressive.
So thank you. I'm a gastroenterologist, and I've been in the VA system as well as here. So there's a lot of parallels with the challenges and opportunities with EMRs. And I've been very involved in a project where we showed that one of our gaps is we have a colon cancer screening reminder. It's worked very well. We've got greater than 80% screened, for quite some time, but it isn't risk stratified. So the high risk people, in our case, people who have polyps and need to get colonoscopy more frequently than every 10 years, we've shown that those folks fall through the cracks. Some other folks are being overdone, so we have some appropriate utilization issues on both sides. But one of our theories was, well, perhaps one of the reasons these people are falling through the cracks is that these reminder systems are geared for every 10 years. We're very dependent on them if we had a more nuanced reminder system. So it's been an almost year-long project to create one, and as you know, what we would create is specialists versus what the PCPs who are stuck using this stuff. So we had primary care input, lots of human factors. They told us, similar to you, they don't want a 100-page document, they don't want 20 screens and 50 clicks. We click all day. So trying to take all those things into account. And I'm very inspired to really try and do what you do as far as the evaluation to see if this makes a difference, at least in the the appropriate utilization for these high-risk groups. Unfortunately, we have the same problem you do, trying to tie high-risk adenomas with codes and stuff. It's difficult, but I think it's worth doing, because is there the question, okay, if we do this nuanced reminder that had a lot of testing and a lot of input, but nonetheless as a reminder, we're not doing a national detailing, we're not necessarily, there's a performance measure, which is one of those things that's reported for screening. There's not a performance measure for polyp surveillance at this time, and I don't anticipate one. So, how much are we getting with this intervention versus how much more? And, what you talked about highlighted all those points, and I just wanted to say highlighted it well beyond chronic kidney disease.
Yeah, chronic conditions. Yeah, I totally agree with you. It's not just a simple intervention. It's got to be a multi-pronged approach that's being taken. And I don't think we have to apologize for doing that either. So it's great, the work that you're doing, and there could be others that are doing other sorts of interventions at the same time, because it's all for the same outcome, right? It's to improve the recognition and diagnosis earlier. So it's well done. Yes.
Can you, or is there ever the thought of doing just auto-triggering? So as soon as if you come back and EGFR less than 35, if they haven't seen a nephrologist, it automatically triggers a referral. Or if someone's,
That's a great suggestion.
or if someone's, creatinine clearance is less than 45 and there's no prior history, you screen for angioedema and the codes, there's nothing there, it automatically flags that this patient is not on an ACE and ARB, has never been prescribed an ACE and ARB, and so they should be, and so it just auto-triggers.
Mm-hmm. They could do that through the primary care EMRs. We'd have to, because that is at the individual patient level within primary care. We wouldn't be able to do it, so that's the one healthcare system where it could be those sorts of things. And they do that already, like that's the CKD, that would be like the dashboard. This one, I showed you how they have the dashboard that they can confirm whether they have CKD or not. So we could add another flag that says, are they on an ACE or an ARB, or those sorts of things. So it could be integrated into their EMRs in primary care.
As a way of just automatically facilitating, because even just the more steps you add for someone to click through, are they on yes or no, it won't happen.
Yeah, and it could, it could have the list of patients who have chronic kidney disease and aren't on an ACE or ARB. You could program that in, yeah. Or if you're at the individual patient level, it could flag if they're not on an ACE or ARB.
Or something.
Yeah.
I guess the trigger of the referral would be hard because the referral goes into a different system.
That's true. It could say this patient needs a referral, and then it'd have to go into the other system to actually do the referral.
Yeah, because we
That's
did
gonna be
something
the
like that, for positive FOBT fit. There was some places that do an automatic colonoscopy referral or an automatic GI referral, and of course the gastroenterologist hated it, kind of the same reason, because there's all these clinical caveats. They always have to balance the automated to make sure it gets done versus the inappropriate referrals because of all the clinical stuff. But in this case, I think once you get one system, those types of referrals will be much easier, because it sounds like the referral issues were kind of onerous right now.
Yeah, it's two systems and they don't talk. Yeah.
Because I was thinking to that idea of all the care isn't necessarily protocol driven. I mean, there's probably a lot of care that could be done better through an algorithm, but some that's nuanced and based on specialty knowledge or your awareness of a shared decision-making event or a competing risk that's being taken into account in how you manage the patient. And I wonder if any of these systems, or if anyone's looked at systems that could be, there may be a starting point that's set through an automated process, but then there is the ability to modify the care plan for moving forward, sort of to turn it off, or if you knew that there was a high-risk adenoma and you wanted to change the frequency as the specialist, and then have that prompt the primary care provider. Is there a way for this to be a communication tool that could be customized?
Two-way?
Yeah, two-way between the specialist
Yeah.
and the primary care provider that could be customized over time.
Yeah, within the same EMR.
The same platform,
Yeah.
maybe there would be an algorithm that would give you a starting point, but
Yeah.
then the specialist would
There's
add
no
their recommendation.
ability to interact.
And that's,
Yeah.
how we've tried to set up our reminders. So the person who does the colonoscopy to, diagnose the adenoma is the one that sets the timing. So rather than sending a letter to the PCP, we recommend your patient get their next colonoscopy in 5 years. We set the reminder for 5 years.
Oh, okay.
And we also set it up to be able to be turned off by anybody, either turned off temporarily, like someone has a massive MI, so we kind of want to see, or they have a new diagnosis of cancer, or they have some, huge stroke, turn it off temporarily, and also turn it off permanently. Because that is, part of the problem back to the PCPs. They get all these
Yeah.
reminders that are on, they're inappropriate, it's really annoying. The temptation to order a test or click a box just to get rid of the reminder is huge. So,
It's a balance,
these
right?
things
Like, you don't
all
wanna
come
be-
up.
Yeah.
But we try to incorporate this because we've, come into, all those situations. So, who turns it on, who sets it, how you turn it off. There was a lot of concern, if we turn it off, what if it gets turned off inappropriately? So it's like, okay, for these circumstances, you turn off for a year, it turns back on, then you can totally turn it off, So all this, there's a reason why this rollout is going to be, a year after the first, conference call.
Yeah.
But those are all possible.
Yeah, and all positive steps too, right? Like those are great ideas.
I wonder if there's a way to even bypass the primary provider and get some type of information to the patient, so that the patient is prompting
That's
the physician about this stuff, right? I mean, at least the well-informed patient has the ability to say, hey, what should I be doing for diabetes or proteinuria or kidney disease?
That's exactly what we're thinking about. So all of our interventions so far have targeted the provider, and so now we're looking at some interventions to target the patients. And so we've had some discussions with the lab. So if somebody's got CKD, sending a letter to the patient and saying, have a discussion with your GP about a statin or an ACE or ARB. So and they do it in Alberta for cancer screening. So they've got a cancer registry, and they use the provincial registry and see if, so females, for example, after the age of 50, you'll get a letter saying, have you had your mammogram? Or why haven't you had your mammogram? So they're doing it for cancer, so why can't we do it for CKD? I think it could be another potential. So to provide that letter directly to the patient, and the patient uses it.
You mentioned the word dialysis. I think it'll get there.
Yeah.
It does work. I mean, when we, we looked at studies, if you send the letter, sometimes if you send the, reminder to the physicians, unless they're in the patient record at the time they get the notice, so unless it's, within the EMR, it doesn't have any impact because, you get this notice and it's disparate from the point of care. You've got too many things going on then to go back into the record for that one patient. But if you send it to the patient, it had a better outcome as far as, this was uptake of cancer screening again. Because, they have it and they're thinking about it until the next time they see their doctor. So, there's some good evidence, at least in other areas, that sometimes the patient letters work better than the physician letters, depending on, how it's delivered.
Yeah, facilitated relay is the term. Yeah. Thank you very much for your attention.